I find that coordination of care to be one of the top 5 most exciting things going on in healthcare in America. And I say America because I'm not sure there's that much coordination of care going on anywhere else. So just like we invent a lot of things in the world, I think we're inventing coordination of care. And I don't think it's because we're American. I don't think it's in our DNA. It's because I think there's a ton of money in it. And so one of the things that we've been testing is, well, what if we build a network around this primary care group of specialty providers and hospitals? What would happen?
It's also possible that care coordination as a business or as a function is more popular here because we're less coordinated at the outset. I mean, for example, many of our peer countries have a national electronic medical record. That in and of itself promotes coordination in a way that is not possible here in the US for all sorts of federal policy reasons, right? And consumer related reasons.
Welcome to Analyzing Healthcare by Scale Community, which is an education-focused organization comprising of passionate global healthcare leaders. Analyzing Healthcare is Scale's podcast series dedicated exclusively to unpacking the myths and foibles that have been directed at US and global healthcare for as long as we can all remember. Is US healthcare broken? The worst in the world? Perhaps, perhaps not. Let's find out together as we invite the thought leaders of healthcare to share their views. I'm your host, Roy Bejarano. All right, so I'm happy to introduce Dr. Robert Fields, who is a proven expert in all things population health, currently serves as the EVP and Chief Clinical Officer at Beth Israel Lahey in Boston, Massachusetts, formerly Chief Population Health Officer at Mount Sinai in New York. And yes?
I said that's right. You got it right.
Yeah, I got that right. All right, we're off to a good start. And it's wonderful to hear from you, have you here on this podcast, because population health, that's one of those terms that's used by a lot of people, especially within healthcare. And for a lot of us, have we really slowed down to understand what we mean by it? Yeah. And so I want to start with maybe a little bit of your journey and how you ended up in this field, but very quickly turn to just how you define population health.
Yeah. Well, the short story is that I'm a family doc, primary care doctor, and never intended to go into leadership, or certainly I didn't know anything about healthcare economics at the time, but I knew I wanted to be a physician, a primary care physician. Did my training in Asheville, North Carolina, after medical school at University of Florida. But one thing that has driven my career and informed it is I was born in Puerto Rico. My mom's from Cuamo. I was born in San Juan, despite my very American name. My dad's from West Texas. But I spoke Spanish. And so when I finally got into finishing residency, I opened a practice with a good friend of mine from residency. And our practice was very much a bilingual practice. We named it Vista, so you could say it in both languages. We hired all bilingual staff. We were early in technology. This is 23 or so years ago. Early in technology with an EMR and patient portals and e-prescribing back in the day. And it was all great. We grew tremendously. In so many ways, it felt really, really good. Financially, it was a total disaster, because we were trying to do lots of things. First of all, we didn't know how to run the business. We didn't know anything about it. We just thought it would kind of take care of itself. We were just doing the right thing and working hard and seeing lots of patients. And it didn't work out. And some of the problems that, there were several, but at least one of the problems was serving a population that was underinsured or heavily government payer and affected our payer mix to some degree. And it just affected lots of things about revenue and learned some hard lessons in a very personal way. It was very, very challenging for all of us partners in the practice very personally in terms of our financial impact and stress. Ultimately became employed in the hospital, but it got me thinking about why doesn't it work? Like, why is the system so broken, and why are incentives so misaligned? When you thought if you work hard, you're doing the right thing, and you are serving people in the way you want to serve them, why don't the finances work out? And did get interested in policy, got involved in local and state healthcare sort of politics and policy through the medical society and things like that, and also got involved in ambulatory quality and safety as an employed physician. And somewhere in that mix, our CEO had come from Geisinger, was really wanted to start a value-based network. And I was lucky enough, honestly, to some serendipity, be in the right place at the right time with 2 other people. And we built the first network in Western North Carolina there, just as the ACO movement was in its early stages. And so we built our first value-based network and a Medicare shared savings program and got involved in our first value-based contracts and had a lot of success in the 20 county region in Western North Carolina. That launched some opportunities to get involved nationally with the National Association of ACOs, and was the board chair for a period as well, and served on the board for many years. And I feel like I, in many ways, grew up there, learned a lot about national politics and policy. And then there was recruited to Mount Sinai first as went from Asheville, North Carolina to Manhattan, was there as a chief medical officer for population health, and then later the chief population health officer running managed care and population health operations, which was great. It was integrated, so you didn't have to compete with the fee-for-service. It was all one strategy, right, and how we progressed forward. Learned a lot, and then eventually was recruited, actually 2 years ago today, to come to Beth Israel Lahey as their chief clinical officer, which means essentially I run most things that are not hospitals. So yes, I do the quality and safety medical affairs things that CMOs do, but I also run primary care, behavioral health, home care, lab, pharmacy, managed care, pop health, and digital strategy, and digital innovation. So it's a broad portfolio, but it's all non-hospital based, which I really like, because I think that's where the future of care is going. And I think getting to answer your question on what is population health, to your point, everyone defines it differently. But I tend to think of it more clinically, where we reorient the delivery systems to think less about, or at least not 100% on just the very individual that's in front of you. We obviously think about that every day, but also thinking about how we think about our communities, how we do proactive outreach and manage as a sort of delivery part of public health, how we manage chronic conditions and other impacts at the macro level, and also how the policy and economics impact that care at that level in communities, and how we can reconcile those two things. So I do think of population health as really, in my mind, from a practical perspective, a mix of that delivery model and the economics underneath it.
So that's a lot of background, and it's very much appreciated. I feel like I've arrived at the right train station to unpack a few important questions that I've been picking away at for a few years now, but I still need some more calibrating. So I'm looking forward to this, Dr. Fields. So
and Rob is good. Please call me Rob.
I'm gonna call you Rob. So I'm an ACO, and I'm interested in wellness visits and vaccinations and monitoring my patients' chronic disease. I'm interested in all kinds of things: care coordination, outcomes, admissions, hospital admissions, readmissions. And I'm interested in these things because in addition to my PM, per member per month payments, which are fixed, I also get a variable bonus based on performance. How my patients do relative to expectations. Did they visit the hospital more often than they should have, less often than they should have? And I want to avoid penalties for excess utilization. And the structure of this is being defined for me mostly from up above: Medicare Advantage, ACO Reach. How is that different than a chief population health officer at either Mount Sinai or Lahey? And how does one position differ from a very formulaic, fundamental standpoint, not necessarily from a philosophical standpoint? We'll get to mission later, but just the practical KPIs, key performance indicators, that you monitor as the head of an ACO or the founder of an ACO versus the head of a hospital population health department. Is it the same job, or is it different?
It's absolutely different. Although, I would hope that anyone that's in a similar role to mine at any institution would be paying attention to some of those same KPIs that the head of an ACO would, but they are definitely a different job. And I think that's driven not only by the regulatory environment, but just the practicalities of the industry at the moment, where it's no secret that despite a lot of rhetoric and investment, frankly, on the value-based care side, it represents a fairly small percentage of total revenue in the healthcare industry and for most delivery systems. People try to get cute with it, I think, and count pay for performance as part of that. But I'm talking about real, value-based care, population health, where the significant chunks of your revenue are really coming in from a risk perspective, total cost of care.
We hear different things, right? I was speaking to Liz Fowler, the former director of CMMI, about total savings generated, and they're very proud of that multi-billion-dollar number. We hear about the tens of millions of patients that are part of Medicare Advantage as opposed to Medicare. 50-50 is the rough estimate that I carry in my mind. 50% Medicare, 50% Medicare Advantage. Medicare Advantage is described entirely as value-based care. So that sounds like a lot of penetration. On the other hand, I anecdotally understand that it's more than anecdotal. It's also empirical, because I speak to so many healthcare provider groups across the country, across all specialties, and there's very little penetration in clinical single specialties. Value-based care, when I see it in primary care groups of a certain scale consistently, and multi-specialty groups. But keep going.
And I agree with everything you said, but I think we have to unpack that a bit. I want to start with the last point first. I totally agree with you. What the best examples, and there's empiric data to show that really primary care groups and primary care led ACOs are better performers in true risk than health systems as a rule. That's been fairly well documented, and I believe it. I'm a family doc. I get it, and I understand why. We saw part of the reason we were so successful in North Carolina is such an intensely supportive primary care environment with a long tradition. I think that was a huge driver of our success. So I believe in it. However, I've chosen to spend the vast majority of my career, once I left independent practice, in health systems, because still the vast majority of the care in the U.S. is provided in health systems, and we're not going to make that seismic shift until we get health systems to think that way. So it may be pushing the rock up the hill here a little bit, because it is hard for lots of reasons. But I still think I don't disagree with anything you said. And also we need to get the health systems there more aggressively, because I think the first point is absolutely right, that when you look in the delivery systems, it represents a small percentage. I think Liz is right. I have a huge amount of respect for her and what she's done. And I, again, being involved on the Medicare Shared Savings Program side, I do believe in the importance of traditional Medicare and what it can do. And I frankly believe that the savings that have been reported in the Medicare Shared Savings Program are real and valuable and good examples, and personally think we should invest more in that program from the federal perspective. I feel differently about Medicare Advantage because it is very much clouded by both shareholder profit in some cases, right, in terms of what's value to the taxpayers, but more importantly on arbitrage on other things about the Medicare Advantage program that are unique to that program and not true in traditional Medicare, whether it's how benchmarking is done for those plans in certain communities, and what sort of I would say self-serving selection process often occurs with that benchmarking process. And then the risk adjustment piece, which is true in the Medicare Shared Savings Program as well, but doesn't have nearly the same sort of direct value. And we know many examples of where that sort of arbitrage has gotten a few folks into trouble over the years from a regulatory and compliance standpoint. So I struggle with believing the savings quoted by many of the MA plans that actually is real for taxpayers. And frankly, given that more than half of the Medicare beneficiaries are enrolled in Medicare Advantage, and the Medicare Trust Fund continues to be depleted at a pretty incredible rate, I would say it's hard to know if savings were true, where that is coming from and where it's going. So I take lots of issue with that. Having said that, Medicare Advantage is real. It's growing. It has advantages in some cases to the consumer. I would argue that we could make those same advantages in traditional Medicare if we just make policy choices in a different way, but we don't do that. We give Medicare Advantage plans a bit of an advantage there. But they're here, and they're likely here to stay. And certainly with this administration, likely to grow. And so if that's the case, I as an executive in a large health system need to figure out how to work with those payers and partner with them wherever possible, because it's a reality that exists. As a taxpayer, would I rather see traditional Medicare grow? Absolutely. But the way I might vote is different than the way I need to operate in my life, right? And how I work.
So it's a lot to take in as an audience member, that there's two different institutions in the government, and Medicare Advantage is generating real savings through CMMI, CMMI, I think is the right acronym, Center for Medicare and Medicaid Innovation.
Right.
And yet there's this other institution that's equally large, Medicare Advantage, that's also approaching the problem set from a similar direction, which is, let's focus on primary care. Let's focus on stratifying patients based on risk. Let's focus on creating networks, closed networks, where we can control quality, outcome, measure outcome, and make decisions accordingly. Fine-tune number of wellness visits to increase health and reduce untreated care, which turns into chronic care. Think about hospital readmissions, those hospitals that readmit too frequently. Let's move our patients into a different location that readmits less frequently. So you'd think that they would end up in the same place, but as a layman looking at it from the outside, it's Medicare Advantage star ratings that need to be adjusted every 2 or 3 years. And all of a sudden, these large payers complain that they're losing suddenly large amounts of money because their star ratings have taken a hit. It's Medicare Advantage that you read about, primary care groups that ultimately, when they were really studied by another objective third party, they didn't generate the savings or the reduced readmission rates that they claimed they did, and there really wasn't improvement. And yet, so it's conflicting insights.
Absolutely.
And I struggle with the ultimate assumption. We're trying to build technology products at scale, and sometimes my technology team come back to me with, I'm trying to build this and it just can't be done. And then you're left with these foundational logic questions. And so a logic question in Medicare Advantage is, isn't there a lot of low-hanging fruit here? Anytime that you create a network and you start to analyze performance in a contained, controlled environment, in this case, healthcare and outcomes, shouldn't they be generating a lot of savings every year just by doing that? Or I'm oversimplifying because there's a benchmarking component to this, and what you generate one year now drives the benchmark or the control for next year. And so there's a resource allocation. There's a lot of complexity here. So why are they arriving at two very different outcomes? Medicare savings versus Medicare Advantage.
Yeah, I think it is. You're highlighting the complexity. It is complicated. And
yes,
I think there are a couple of things that are, like, when I think about root cause, that are underlying this. I think one, when you think about the difficulty in comparisons, is that they are fundamentally different economic models and the incentives are fundamentally different. So what drives value-based programs in traditional Medicare and what determines success or failure in those programs, frankly, has only a very loose relationship to what drives success or failure in Medicare Advantage.
And what are those two differences? I'm very interested in this.
Yeah, so you mentioned benchmarking. I think that's a really important one. How an institution or a delivery system, a network, probably the best word of all, a network that's participating in a value-based initiative in traditional Medicare. In general, the benchmark is based on their region with some puts and takes of how big the region is, what defines the region. Are your own expenditures counted in that region, or are they removed? So you're really just comparing against everybody else and not yourself. So there are some details that vary. But it's comparing your price or your expense in traditional Medicare for similar services to a market. Broadly speaking, that's true. In Medicare Advantage, often the benchmarking is actually driven by the costs as determined by traditional Medicare insured patients. So it's not even the same population. So you have a privately insured Medicare group that in their prices are compared to people who are on traditional Medicare, with the assumption is that they should be the same just because they're the same age, and they're not. That's fairly empirically shown, is that those populations tend to be different. Traditional Medicare patients tend to be sicker. They tend to go to the hospital more. And there are lots of reasons underlying that. Like, it's the default plan.
It sounds a little generous to start with.
Yeah. That's definitely true. But so you can imagine then, if you have a population that skews slightly healthier in the private plan, but you're being compared against a population that skews sicker and that utilizes more services, and the revenue you're getting from the federal government is based on those sicker patients, but they cost less in your area. You've already built in some degree of margin in there just by the arbitrage of the comparison groups. There's
and
yeah.
the incentive from a provider standpoint is to try to call your population as sick as possible.
Absolutely.
And hope that they're not, and then you'll pick up that spread as well.
It's right. And so that's an additional layer. So that's even before you've done the risk adjustment piece that we were talking about before, which, you know what, on its base makes sense. You should get, if you have a sicker patient, you should get paid more, essentially a bigger budget to care for that sicker patient. That intuitively makes sense. The problem, like any system, is that people have learned how to game the system, including the plans, to try to drive that revenue. In fact, we know when you think about tech and then on the related, the venture space, what is very clearly true when you look at the valuation of these companies, certainly in the peak, you look at 2019 through 22 or so, where just unbelievable investment in this space from the venture and private equity side. When you saw the revenues that were being reported, it was really based on the capitated revenue, risk-adjusted capitated revenue that was coming into a company. So if you had 10,000 members, you frankly just added up your total cost of care premium that you were getting for all those members you were taking full risk for, and that was your revenue, right? And then you had medical expenses and operating expenses coming out of the expense side. And so it made, if you partnered with a plan and got 5,000 members, that's pretty tremendous growth. If you figure out the average Medicare beneficiary can be, $15,000 on the low end in some markets to tens of thousands of dollars for a super sick patient, that's a lot of revenue. And so it made the valuation of these companies insane for several years without any real proof that they could manage utilization and cost of care. And the arbitrage of risk adjustment can only take you so far. And I think a lot of folks paid the price from an investment standpoint. And a lot of companies have folded because it turned out they never proved profitability. And so that reconciliation of what's a successful business and what is mostly arbitrage on taking advantage of the structure of Medicare Advantage, I think that it was not clear early on. It became clear later because very few companies really survived that really in perpetuity. There are some examples of folks that have really made their business really focused on traditional Medicare. And again, I go back to, I just have a fundamental belief in my experience that those savings reported in the traditional Medicare plans are closer to the truth, just because there are fewer opportunities for that level of arbitrage. But you can make any number look good, I suppose.
I appreciate that you're a man who seems to have an affection for the truth versus short-term unsustainable wins. So it's interesting to hear you describe the journey, the evolution, the devolution of Medicare Advantage from a true value gathering perspective, because it rings true for many accounts in history, in corporate history, that have been fueled by government regulation. It is amazing how many industries and companies have been born on the back of government policy throughout our history here in America. It's very common. Government passes law, a whole new industry emerges. But it's also true that every time that happens, it's almost like the private sector role is to highlight the errors,
the flaws
that existed within the policy. And so right. The difference between theory and reality, no matter how many pages, how much law, how many pages, 2,000 pages of law went into ACA. Whatever the issue, whatever the mistake is on page number 63, paragraph number 4, you can be sure that the private sector will find it.
We'll find it, yeah.
But it won't point it out to the government. It will just build a business around it if it's profitable to do so.
Right.
And then someone like you will find it because you'll look at that business and say, there's no there.
Right.
I appreciate that you're generating good revenues, but you're not actually making patients healthier, are you?
Right.
So it's just very interesting to hear this. It begs a lot of questions. Like, I'll give you another analogy, alternating current, direct current. I mean, when we first started in, 1890, 1900, direct current was on its way to being the standard across the country. If it was up to Edison, we'd be using direct current. And we would have 10% of the world that we have today from a technological standpoint, if that.
Interesting.
We would be moving at a fraction of the speed that we move at
Mm-hmm.
you can forget Elon Musk spaceships to whatever. None of that exists on that inflection point. And thankfully, even though he tried to kill AC with a very large lawsuit directed at Westinghouse, Westinghouse overcame, and AC proved itself as more efficacious, and it won. So I'd like to think that the better technology, the better way of doing things ultimately wins. And yet here it's Medicare Advantage that's everywhere, and it's Medicare savings, shared savings, that is not. So explain that.
Yeah, well, I think what we haven't yet talked about is the element of consumerism and all this. The U.S. environment is complicated in lots of ways. We want our cake and eat it too. So I would say two major things that I mean.
We definitely eat a lot of cake.
We definitely eat a lot of cake.
Personally guilty myself.
But I think what I mean by all those sort of words is like there are really two things in my mind. One is that we haven't fully reconciled.
Keep going. I'm listening. I'm getting my charger.
No worries. We haven't fully reconciled the expectation that healthcare is, if for all practical purposes, a fundamental right in the U.S. with how to finance it. And so we haven't reconciled that.
Oh my God, you're singing my choir. Like literally, that is the number one statement that I think explains the friction within our industry.
I think it's when I go back, it's the root cause.
Everyone deserves everything. We can't yet afford it.
That's right. And then we also want everything at the same time, which we definitely can't afford. So there's that. And then there's a second piece where, look, why the health system is broken is that we are all complicit. Every single part of the value chain, frankly, including the citizens of the US, because we make choices not on value or cost or quality. That's been shown over and over again. We make it on all sorts of other factors that are not any of those things. And so what is the incentive to save money or save total cost of care for anyone? Because that's not how we make choices. And it is those choices that drive margin, even in a nonprofit system. So, right, like that fundamentally, there's a problem even on the consumer side. There are large health systems in my market that are double-digit more expensive than us on a unit cost basis. Yet we struggle to get market share in some cases, right? Because for lots of reasons, the system is not set up for the consumer to care.
The pricing signals are not that loud in health.
That's right. And then you go one step further upstream. How about the purchasers, employers, right? Everyone likes to complain that their premium costs are going up on the employer side, right? There's a lot of rhetoric about it. But try to convince an employer to create a narrow network product as an offering for their employees to only go for the lower cost, higher quality providers. And they won't do it because their employees will get very angry. So right. So it's all like, what's the incentive again to care about the value-based care kinds of principles when that is not how the purchasing of healthcare actually works? So that is in my mind, a huge problem there. And Medicare Advantage is part of the same thing in my mind. It is really attractive to have a zero premium Medicare Advantage plan that covers silver sneakers and dental benefits and vision, because you don't get that in traditional Medicare, which, by the way, is just a policy choice. That's not it's not a statutory thing. It's a policy choice. But Medicare Advantage, has those, and that's really attractive. If you're a healthy person and you like to go to the gym and you get a silver sneakers benefit and some dental care, that's great and really attractive. However, if you're sick and need special equipment or you need a special procedure, that's very challenging in Medicare Advantage. My brother, unfortunately, who we're very close to, has ALS. Thankfully, he has survived with his illness for now 7 years or so. But when he was asking me, when he went on disability, when he lost his employer-sponsored insurance, what kind of plan he should choose, traditional Medicare, Medicare Advantage, said to absolutely go to, if you can at all afford it, do traditional Medicare with a supplement to cover the 20% coinsurance, because you're going to need a lot of DME and you're going to need a lot of extra stuff that's going to be awful to get through a Medicare Advantage, because that's not the business they're in. And that in my mind exemplifies the sort of mismatch. If you're healthy, a zero premium plan that covers the basics and the physical and basic stuff is in screening makes sense. But if you're sick, who's going to pay for it then? And I think I know if you had a health plan person here, they would disagree with me vehemently about this, but my practical experience as a primary care physician for 15 years and a health system executive for now almost that long, I have found that to be true almost universally.
And Silver Sneakers, for anyone who doesn't know, is sort of covering gym membership, basic things.
Oh, right. Sorry.
Yeah,
and,
all right.
and I think it's great, by the way. This is not a diss on Silver Sneakers at all. It's great that we would promote some level of wellness within a health plan. That's not a problem to me. Although I would say, and I'm sure your listeners know this, but there's a big debate right now because there isn't really a lot of transparency on the utilization of any of those supplemental benefits. So we actually don't know how much of it is a sales game that people don't actually use, but we pay for it as taxpayers, right? One way or the other.
So just like everything in life, popularity is not a determinant of
Absolutely.
value. Look, we have a lot of problems arriving at the truth in all things, and you think about the obstacles that we have to fight through in order to get to the truth. I can think of my own forgetfulness. We forget more than we remember. Bias. There's like
totally
20 plus different types of bias alone that are all prevalent, all the time, everywhere. Political bias is huge on both sides. I don't care which party you prefer. That's just reality. Everyone wants to be part of a group. The fiefdoms that are out there, the tribalism that creates bias. I want my team who's wearing a white shirt to win the soccer game. I hate the team in the red shirt. They must be evil. We have the bias of speed and time working against us. We either move too slowly, a bias against action, or too quickly. Right now, we've transitioned from slow to quick in government, and everything has to move now, or it's no good. And so I could just keep going and going and going.
Agreed.
So by the time you actually arrive at this destination called, does this thing actually work? Is it sustainable? Does it make sense? Does it do what it claims it does?
Yeah.
You have to climb through so many hoops. So it's hard. There's not a lot of truth in our lives collectively. I'm speaking for everyone. And by the way, the bias of hubris and arrogance, like, what the hell do I know? As I'm saying this, do I really know what the hell I'm talking about? Maybe I don't. I probably don't. So just another hurdle to climb through, the bias of arrogance.
Right.
So it's just everywhere. There's a lot of hurdles to truth, but it makes it fun. I want to stay on that path, pursuing truth. So you're running. I don't know if you said you were chairman of the ACO organization across the country.
I used to be the board chair of the National Association of ACOs. I've termed off the board.
That's good enough. Good enough for the question. 800 ACOs, 1,000 ACOs, I don't know, it was 500 at the time, give or take, a lot of them. Mostly centered around 3, 4, 5 states, not 50 states, California, Florida, Texas. I'm probably missing 1 or 2, but not that many in New York, where I am. And as a layman on the outside looking in, the anecdotes that we hear about is, most of them fail, only some of them really survive and thrive. And then occasionally, anecdotally, we hear about a very large ACO transaction, tremendous value. Whether it made money or not, no one cares. It's strategic. We'll take your network of 3,000 primary care doctors and we'll pay you hundreds of millions of dollars for it. You've only ever lost money, but who cares? And then anecdotally, you hear about this thing called value-based care, and again, you fall back on the low-hanging fruit. They have to be creating value because who else is focused on coordinating care other than these ACOs across the world? Mm-hmm. I know that there are businesses now that are focusing on it, and I know that there are heads of population health within hospitals that are focusing on coordinated care. But this is their job. They must be creating value. And so you've looked at the whole landscape. You've looked at the entire universe of 800 ACOs. Was there mostly value there? Was there a lot of noise there? Did you think that 10% of them were truly worth the effort, the rub? The other 90% were just riding along, a little bit of a wave? Or is it the inverse of that? Was it 90% Paribo great, 10% bad? What was it?
I would want to start with a couple of things. So even though the term ACO or accountable care organization, I think is a little fraught because, at NACOs, the primary, that's the National Association of ACOs that I was a part of, the primary focus was really on the Medicare Shared Savings Program. We definitely had all of our members, essentially, the vast majority, also participated in Medicare Advantage risk-based arrangements, and they called them ACOs. But, I put a lot of stock in the original Medicare Shared Savings Program definition of an ACO for the same reasons we talked about earlier. There are lots of ACO products, air quotes here, that within Medicare Advantage and the Medicaid space, but I would say that they're not all valued the same. So when you answer the question of did they provide value or not, I would like to really divide out the Medicare Shared Savings Program ACOs, and then everybody else. And even in that everybody else bucket, there's a lot of mixed messages in there. I think that the value created in the Medicare Shared Savings Program, like I said, I trust it more. I trust the outcomes data a lot more. The problem with it is that it's small. Like the savings that program has generated is relatively small to the total. And I think not necessarily because it couldn't provide more value, but it's really all those other trends. We have more patients going into Medicare Advantage. And frankly, the program could be improved if we made different policy choices similar to the ones that are made in Medicare Advantage that would make it more consumer friendly. And so but despite what I think is underinvestment on the Medicare Shared Savings side, I really trust the value generated there. For everybody else, let's say in the Medicare Advantage version of ACO, I think it's a little more mixed. Do I think that there's value? Yes. I think that there's value on the individual patient basis. If you have someone with complex illness, who needs coordinated care, who needs a robust primary care environment, I think there are many examples on the individual basis where an ACO on either side, traditional Medicare, Medicare Advantage, provides value. The issue for me is really when you get to actuarial scale. And you can prove lots of things on the individual basis, much harder to prove at scale across a population that actually makes a difference in really shifting the bell curve of healthcare costs to the left. If the x-axis is cost, can we actually move the whole bell curve? That's much harder to prove. And I think that is, again, to be honest, when you less proven on the Medicare Advantage side of the business. I think there are individual examples of excellence. I think there are individual examples of clinical programs that these networks have created that add value on the individual level. Did it fundamentally change the world? I don't think so, because if that were true, the Medicare Trust Fund would be in better shape than it is.
I don't know. Knowing the government the way
either.
that I do, how a fund is behaving could be a function of many other things.
Fair, right?
It's been lending money to the Department of Defense.
Right. Well, no, absolutely.
When it comes to trust funds.
And the tax base is also starting to decrease, right? So it's all fed by taxes. So lots of confounders there. I get that. You're totally right. And my statement may not be completely fair, although
everything up to that point makes logical sense to me. Then you lost me because there's just too many variables.
I think
never trust a government balance sheet. That's a good rule in life. So ACOs, interesting, lots of signal and lots of noise, maybe even more noise than signal. Lots of ACOs that follow the Medicare Advantage path and have been all over the place. And to some extent, they tarnished the brand ACO. And then on a smaller scale, follow the Medicare savings path. But, is it scientific enough? For you to really hang your hat on it. I will say, when I think of the ACO universe, I think of the coordinating care universe. Mm-hmm. Although there are groups that are not ACOs that are now just coordinating care. But I find the coordination of care to be one of the top 5 most exciting things going on in healthcare in America. And I say America because I'm not sure there's that much coordination of care going on anywhere else. So just like we invent a lot of things in the world, I think we're inventing coordination of care. And I don't think it's because we're American. I don't think it's in our DNA. It's because I think there's a ton of money here. And we throw money at things all the time. And it looks awfully messy, whether it's government money or private investment money or public market money. There's just a lot of incentive to do stuff and test stuff. And so one of the things that we've been testing is, well, what if we build a network around this primary care group of specialty providers and hospitals? What would happen? So I think it's a very interesting space. You were going to push back on that.
Well, I think that it's also possibly true. And like all things, it's probably not as simple as what either of us are painting out to be. But I think just as a counterpoint, It's also possible that care coordination as a business or as a function is more popular here because we're less coordinated at the outset. I mean, for example, many of our peer countries have a national electronic medical record. That in and of itself promotes coordination in a way that is not possible here in the US for all sorts of federal policy reasons, right? And consumer related reasons.
That is a huge point. Even though we have more EMR usage than they do, our EMR usage is fragmented. It's not interoperable.
That's right.
Our EMRs don't talk to each other.
That's right.
A very good point.
I have my own podcast, and I was doing a podcast yesterday with a group of leaders from Denmark who have an innovation center in Boston and talking about healthcare, well, broader tech partnerships and innovation partnerships across Denmark and the US, and health tech being one, and the health industry being one subset of that. It was a really interesting conversation. They were talking about, there's a national identification number that's very similar, but if you want to get your records from any time, you can get that anywhere. And now they're thinking about how to use that massive repository of data for all of their citizens, essentially from birth to death, in a way of using predictive analytics and machine learning and AI to sort of provide care, reduce mortality. Can you imagine trying to do that in the US? Like, how would you actually amass that kind of data set? I mean, and that's the VA, for example. I think they get a lot bad rap for lots of reasons. I think the VA has done some of the most interesting population health work and the most interesting data work than so many other segments of the healthcare delivery system, by virtue of the fact that they've had a unified record for many decades at some point, long before much of the private industry was doing it. And they're capitated. So almost by default, they've had to figure out how to deliver care differently and create models of care that scale in a population health way. I think it's kind of interesting.
Well, look, we have CMS, Medicare and Medicaid claims data. And we have some other repositories too. I'm looking it up right now. National Health and Nutrition Survey. Oh, we have national standards that are repositories, right? Across clinical specialties. Anything that incentivizes Medicare gathering data, gastroenterology. I always remember the adenoma detection rates. That's gathered nationally. But does it compare to a single EMR system? Look, they also pay the price for singularity.
Absolutely.
They have less adoption. Right. And they have less investment.
So that's also true. They made that point, by the way. They were very honest about that.
Careful what you wish for. The reasons why I have the job that I do, poking holes at things, is I try not to just assume too much, because you got to pull on those strings. Yeah. Yes, it's good to have a singular EMR system for access to interoperable data, but where's the funding coming from? Where's the innovation coming from? We are entering the world of AI, but we remain what's the term I'm looking for? By a multiple EMR non-interoperable structure. That is true, and that bothers me. I'm going to try to pick at that problem as an operator soon enough. I just haven't gotten there. I haven't got the courage yet. So,
Roy, and it's kind of back to the beginning when we talk about, like, we want both things, right? We want coordinated care. We want a seamless experience. We want lower cost. We want our privacy to be protected, and we want innovation into when I have something rare and bizarre that I'm going to, have a great place to go that's going to figure that out and treat my, whether it's a cancer or a rare illness or something like that. I want all of, as a
you left one out.
I want all of it.
You want, yes. And I know you mean you include it, but for you, it's probably as a population health chief, it's a given. We want it for everyone.
For everyone, right.
We want a morally defendable,
that's
more
right.
than defendable, a morally upstanding industry. Right. Because health is not the same as high heel shoes or tuxedos.
Yeah,
it just isn't. It's not a luxury. It's something that we really all need, like oxygen. We need our health. Yeah. So I want to go back to these fundamental questions that I started with. All right. So we went down the journey of ACOs, and these ACOs were both good and bad. And you said population health inside of a large system like Sinai or Beth Israel Lahey, very different. How's it different?
It's the fundamental difference. There are many differences, but with a fundamental difference and challenge, which I signed up for, so be it, is that you are, as a pop health person, you're fundamentally trying to create demand destruction on the very kinds of services that keep the system afloat. It's almost like, cannibalizing yourself, in some ways. It's a very difficult
How do you go? How do you go after the cash cows inside of a hospital?
I mean, it's really challenging to do it, right? There was an old adage from, about heads and beds that people have heard historically, is that, any hospital chief financial officer wanted to keep the beds filled. I remember when I first was recruited to Sinai, it was about a year or so after they had published I think it was like a 2-page full color ad in the New York Magazine that had it was a picture of the New York skyline with Sinai in the background off of Central Park East, and it said, "If our beds are filled, we failed." And it was several paragraphs about their population health journey and mission. And I was intensely impressed because it was completely counter to what everyone else was saying about the future. And it proved to be pretty challenging to do that. They would not put that ad out today, to be honest, right? And so but I think that highlights a fundamental challenge. We've created an immense amount of fixed cost assets in hospitals and clinics within these systems, a ton of fixed cost, an unbelievable amount of overhead. And for many decades now, the incentive has been to do exactly what they were built to do, is to provide services, not to
justify the build.
Right. Provide services and continue to grow. And to be honest, the demand is unbelievable. In almost every instance for health systems, it's if you build it, they will come. And that's generally true. Remember when urgent cares got to be really popular in the late 70s going into the 80s and the 90s, urgent care was the thing to do. And the thought was, well, this is going to lower cost of care because people won't go to the ER as often. Well, nonsense. They just use both, right? That's been shown. We just added cost to the system. We didn't decrease cost to the system. So it's very literally, if you build it, they will come. Why I'm optimistic, though, is that my conversations with other colleagues across the country, conversations with my own colleagues here, is that a couple of big things are happening that make value-based care and risk-based arrangements, I think, something that folks that are smart, frankly, and thinking ahead are paying attention to more so than they did before. That is 10,000 new Medicare beneficiaries per day. It's happening. It's coming at you. People call it the silver tsunami. It's happening right now. And at the same time, we have fewer Gen Xers like me. So that's your entire margin of the US healthcare system and the commercially insured patients just disappearing before your eyes because we don't have the population to supplement. We don't have enough working age adults to supplement the loss of the boomers going into retirement. And that's the entirety of the US healthcare system margin. And you've got regional migration of those commercially insured patients leaving high tax states like the Northeast to other parts of the country. So in the Northeast, we're feeling it doubly. An aging population, loss of commercially insured patients in all of our markets, and that's our margin operation. So there's massive revenue compression just by that alone, doing nothing different. And so that's a problem in fee for service, right? Because you just lose more money per unit. If you lose money per unit of delivery, providing more, just lose more. Right, against the fixed asset. And then we had cost.
That's the first ingredient of the 2 ingredients you need for real change, which is pain.
That's right. And unfortunately, I think there will need to be more of it before things get changed. And then there were massive cost implications post COVID on supply chain and labor. And the math is just upside down. And we're all feeling it. I've told lots of folks, I feel like these are existential to the industry. No one is immune, because we all see everybody to some degree. The issue is the runway for the pain is different. If you have a huge endowment and a better commercial mix in a market where commercial populations are growing because people are moving to your area, you have a longer runway.
But that also explains hospital premium pressure. Wherever we're making money in fee for service, we need to drive up those prices exponentially to cover for all the low paying patients that we're seeing in the North.
Absolutely. That's exactly it. And then and so then on top of that, so we have that math problem that I just described. And then you have, and to your point, the smaller commercial population, the pressure to bump up the price to make up for the loss is significant. But you have the safety net hospitals that don't have any really runway, and they're closing. I saw an article in Becker's a couple of weeks ago, 17 hospital closures in the US just in January through the end of February. It's unbelievable.
Continuing a trend of hospital shrinkage that we've seen for 40 years.
Yep. And it's going to get worse before it gets better. And then there's a second piece, which is really demand. as folks age into Medicare age patients tend to utilize hospital services, something like 3 to 4x the amount of commercially insured patient. So even though revenue is compressed, and the workforce is aging out at the same time, so we have the workforce stressors, we've got demand that's many multiples of what it has been in the past because of that same demographic shift. So we have a supply-demand mismatch on our capacity. It's straining everybody. Who doesn't have dozens of boarders in any hospital of any size, has dozens of boarders in their emergency room? Our length of stay is going up. We have throughput issues. The system is clogged.
Don't worry, Rob, because AI will fix everything by next Friday.
And by next week. Well, I'll be waiting then. That'll be great.
I kid you not. This is the perception out there right now.
Yeah, it is. But I think those two problems are huge. And so then at least now the basic principles that we talked about at the beginning of what is population health start to make more sense because, all right, I'm going to have to survive in the government payer space. How am I going to survive? Well, it's not going to be for fee for service. Maybe, I need to get good at managing risk, total cost of care risk. I need to create demand destruction because I have such massive supply demand issues. I need to.
My problem is demand. Yeah, my problem is demand.
Right.
Yeah.
So I feel like people are paying attention a little bit more. We'll see if it translates into action. But I think those two shifts are changing the conversation.
And included in your description of what you do is addressing social determinants of health. Is addressing social determinants of health just a very academic way of saying, let people understand the benefits of a healthy diet and a healthy physical exercise? And if so, why is that the hospital's responsibility?
I certainly don't think that that's at all the vast majority of what I mean when social.
I think that I by the way, just caveat. I love a dumb question occasionally. That definitely is a dumb question, but I like it. I'm proud of it because I want to elicit in you a critique of what I just framed.
Fair enough. Well, you baited me into it.
Yes, I heard it. I heard the visceral reaction.
Like, the cringe.
This is almost like a poker bluff.
I'm not a good poker player, clearly. So, obviously I think at this point shouldn't be any debate that the environmental and social factors that we all live with have a greater influence on our outcomes than our clinical conditions and our genetic code. Tons of studies that would indicate that, and lots of just life experience that would indicate it. Just look at mortality.
You're not doing well with no exercise and 300 pounds. It doesn't matter what your DNA is.
Or if you live in poverty and public housing, and Sinai literally straddled the southern parts of Harlem on one side of the system on the Upper East Side to some of the wealthiest families and per capita income on the southern side of Mount Sinai. We literally were straddled on both sides by massive disparity. And you look at the mortality difference in just a few blocks in New York is just.
I know it. It's shocking.
It's
like
shocking.
20 years difference in life expectancy from 90 down to 70.
Yeah, absolutely. So I don't think people debate that too much. But your other point about why is it our responsibility? It doesn't have to be, but if not us, then whom? And if you're going to be serious about managing total cost of care risk, then you should at least have consideration for how you're going to address those issues, or you're going to lose because you're just fighting an uphill battle. Early in my career, when I first got into pop health, I worked with as a community engagement person, kind of like a social worker, built social programs for our community benefits team. And she said, it's hard to take care of your diabetes if you live in a tent, really abruptly in a meeting. Like, that's true. As it turns out. And so if you're trying to improve outcomes in diabetes, but you're dealing with populations that don't have a refrigerator and can't store their insulin, what are you doing? You're writing a prescription for nothing. It's effectively a waste of time. So I think it's foolish to think that we don't have some amount of responsibility. I think where people get freaked out about, I think for good reason, is that it's overwhelming. The idea that we're now all of a sudden, on top of everything else we're expected to do, need to be responsible for housing or food or transportation. That's a tough sell for busy clinicians and busy systems that are overwhelmed already. And I think that's fair. But I think there's an opportunity for thinking about that differently. There's certainly technology that helps with the referral, right, to the nonprofit sector. But I think what's missing is a real operational layer that really.
I think it could be branded better.
It could be branded better, but I also
I'm a branding kind of guy. I'll give you an example.
Yeah.
Nursing home villages or retiree villages, assisted living. They also use terms like communities, right? No one bats an eyelid. Everyone knows what it is. It's holistic, social determinant care, soup to nuts. We think about your food options. We think about your daily routine. We think about your access to the pool, the cold plunge. We think about the size of the roads, the handrails, the steps.
Right.
We think about everything. No one bats an eyelid because we are trained as a populace here in America, and we're always a good guinea pig for everything because we try everything and we complain about everything. Perfect study, right? But so what passes the test is branded well. And yes, the idea of the sick, once they reach a certain age, requiring assistance, assisted living, is understood by us, right? But there's a skepticism and a confusion over what socially determining behavior is for the average 40-year-old living in certain zip codes within Queens.
Yeah.
Like there's a potential, there's too much vagueness in that title. Are
That's
you
fair.
gonna dictate behavior to a 40-year-old male in Queens? Doesn't he have the right to make his own decisions? Where do the boundaries end? And what rights and what knowledge and expertise? You spoke about execution from an operator's perspective. Do we have the means to do this? Think about execution from a community perspective, right? The ecosystem of different constituents that need to buy into you, Rob, driving social determinant outcomes and behavioral changes within a neighborhood. Like you need a lot of buy-in for that. Right?
You do. Yeah.
So I think we've got a branding issue there. It doesn't mean it's not solvable. It's amazing what a heading will do for a movement.
I tend to call it social care more often these days.
Yeah, it was good. It was good.
To think about how
I don't know if we're going to solve it on this phone call, but it's worth thinking about.
I do think about, there's a really, people that have heard me talk about this. I have my favorite maybe slide of all time. The Commonwealth Fund has a slide that shows all of our peer countries, and yes, we know we spend more than everybody else. That's old news. But if the one that it shows a bar graph and it combines social or public spending, public health spending, and medical spending in one bar, and we're actually in the middle. We're actually pretty average compared to our peer countries. It's just the proportion. We spend so much more on healthcare than we do on public health and social care. And it, while I would love that policy to sort of change, that we would do more public health, more upstream thinking to handle these issues from a policy perspective, I don't imagine that's happening anytime soon, and certainly not in this administration. So then I think, is there a way, which is another reason why I'm just such an advocate for population health, is use risk-based premium dollars to pay for social care, and not that the health systems are provisioning it, but we partner more in preferred networks with nonprofits, much like we have preferred networks of post-acute facilities. Can we have preferred networks of nonprofits in the various themes like housing, food, transportation this is their business. They struggle from revenue. They have to get grants and philanthropy to stay afloat. But I think we can create a quasi claims-based system with existing technology. Z code for as a quote unquote diagnosis. We have all sorts of technology out there in the private world that helps with that referral basis, that can help collect the demographics, organize the network, effectively do an attestation that a service was provided. That's a claim. That's essentially all the elements of a claim. And we create a fee schedule based on those sort of interventions and redistribute healthcare dollars to pay for these things. Everyone that's taken risk would benefit, because theoretically, if you provide enough of that, it could start to have actuarial value. And so total cost of care goes down. It's pennies on the dollar of the catheterization we're doing, for example.
It is interesting. Can we grab economic incentive from different channels, partner with groups that are not economically incentivized but don't mind, who are well positioned to do the heavy lifting, and support them in ways that they're not used to seeing those levels of
Exactly.
support. I'll give you an indication that I think you're sniffing in the right field or forest. We don't champion our nonprofits very well. I mean, the average person in America can name you the Magnificent Seven: the Google, the Amazon, the Facebook, the Meta, right? The Tesla. They can all name it. All 350 million of us know about these famous technology companies.
Absolutely.
Can they name you the 7 most magnificent nonprofits in this country? Not in terms of news headlines associated with criminality and controversy, but based on excellence.
Yeah.
And so that's a sign that we've probably overlooked that entire space and what we can do. collectively, what we can do to champion the champions. All right, we have reached the end of this podcast, but I'm going to do what I rarely do. I'm going to promise you on the podcast that I'm going to call you straight after this and try to continue to annoy you, probably for another one, because this was a lot of fun.
It was a lot.
I feel like we've scratched a little bit of the surface here. There's more to come.
Yeah.
There's some big questions that I have ready for you.
All right, I'm ready. No, this is fun, and I appreciate you having me on.
My absolute pleasure, Rob. Thank you.
Yeah, it's good to see you.
You got it.
Thank you for joining us on Analyzing Healthcare. Stay informed and stay inspired. Don't forget to subscribe and visit scale-community.com to become a Scale Community member. Until next time, keep exploring the ideas that shape our healthcare systems.